Hello, and welcome to a brief discussion on special projections of the cervical spine. There are 4 special projections that we're going to discuss in this lecture. Some of them you may already see at clinicals, some of them may be new to you. So let's start by looking at flexion and extension laterals. First of all, you would never attempt flexion extension laterals on a trauma patient unless fracture has been ruled out first. So let's say you do a routine cervical spine series, or maybe they have a routine cervical spine CT scan. There's been no fracture indicated. Then a physician could order these after you've ruled out any fracture. So again, you'd never do these on a trauma patient without ruling out fracture first. The flexion extension x-rays are really functional x-rays, which demonstrate any anterior or posterior vertebral mobility. And what that means is we're looking for any anterior or posterior movement of those vertebral bodies. And this exam is frequently performed to rule out whiplash, or more commonly as a follow-up after spinal fusion surgery. And again, the physicians are looking for any movement of those vertebral bodies. The patient should be positioned in a true lateral. We typically do left laterals again. The shoulders should be nice and relaxed. If they can, you can have them hold sandbags if they don't have weight restrictions. You're going to use 72 inches SID, again, because of the oid. You want to center again at C4, just like a typical lateral. And you would do this on expiration, encouraging the patients to relax their shoulders. When you're doing hyperflexion, which is the image you see on the left here, you're going to ask the patient to tuck their chin or depress their chin until it touches their chest, or as much as the patient can tolerate. Don't let the patient move their whole torso forward, though, because that could result in you clipping anatomy. Hyperextension, which you see on the right, you're going to ask the patient to raise their chin and tilt their head back as much as possible. A nice easy trick for this is to ask the patient to look at the ceiling. Again, make sure they don't move their whole torso backwards so that you clipped any posterior anatomy. Okay. Now again, Bontrager is indicating these as hyperflexion and hyperextension. At clinicals, you'll hear them called flexion extension. So how do you know you're correctly positioned? Well, you want to see C1 through C7, just like a normal lateral. You want to make sure there's no rotation, so the patient is in a nice, perfect lateral. In hyperflexion, you should see the spinous processes separated. So there should be gaps in between the spinous processes. In extension, you should see the spinous processes in close proximity. So see how they're closer together here and there isn't as many gaps or as wide of a gap. And then of course you should use optimal exposure factors so that you can see all the bones adequately. Okay, good. So again, flexion extension views are pretty common out at clinicals. Let's move on next to the Fuchs method. Now the Fuchs method is an alternative to the AP open mouth if you're having trouble seeing the dens. So let's say you try the AP open mouth and you just can't get a good look at the dens. You could try the Fuchs method instead. So you can see here the patient is positioned in an AP projection. You can do this on the table or standing. And you're going to elevate the chin so that the mentomeatal line, so you can see that abbreviation, MML is mentomeatal line, is perpendicular to the image receptor. So let me explain what that is. The MML, or the mentomeatal line, is the line from the mentum, or the chin, to the ear hole, or the external auditory meatus. So it's an imaginary line from the chin to the ear. That line should be perpendicular to the image receptor, or as close to perpendicular as you can get. Okay, the central ray should then be angled to be parallel to the mental-meatal line. So for example, let's say your patient can't extend their chin up this much. They can't get mental-meatal perpendicular. Then you would put on a cephalic tube angle to match that line. In this case, the MML is perpendicular to the image receptor, so you don't need a tube angle. Okay, so in other words, your tube angle matches this line in between the chin and the ear. And then your central ray should enter just below that tip of the mandible. So you can see the central ray here, the crosshairs are right below this mental point or this tip of the mandible. Okay, so that's the Fuchs method. You could also do something called the Judd method. The Judd is also an alternative projection for the DENS. The only difference here is the Judd is done PA. So the Fuchs is done AP, the Judd is done PA. So the patient can rest their chin on the image receptor, and the goal of that is to place that mental-meatal line perpendicular to the image receptor. So look, mental-meatal line should be perpendicular to the image receptor. Then the central ray should be parallel to that line and enter the level of the occipital bone. And I know we haven't learned the skull yet, but the occipital bone is the bone in the back of your skull. So in other words, if your patient can get MML perpendicular to the image receptor, you don't need a tube angle. If there is a slight downward angle of MML, then you could put on a slight caudal tube angle. And remember, your tube angle should be opposite. If you use a cephalic tube angle for the Fuchs, you would use a caudal tube angle for the Judd. Okay? What I really want you to take away from this discussion is that the Fuchs and the Judd are alternative projections if you cannot see the DENS in the AP open mouth. Okay? The central ray should be at the level of the mastoid processes. Well, we haven't learned that yet either, but the mastoid processes are the space in your skull right behind your ear. So again, same level as the occipital bone, and that's the level at which your central ray should enter. So let's take a look at what the Fuchs and the Judd look like. Notice the DENS. You can see that here. Here is the DENS. It should be within the foramen magnum. And if you remember the foramen magnum, that is the large hole at the base of your skull that the spinal cord passes through from the brain. You should evaluate for rotation by looking at the mandible. So here is one gonian angle. Here's another gonian angle. Remember, those are the angles of your mandible. Those should look symmetrical. If those angles of your mandible aren't symmetrical, that tells us we have some rotation or even some tilt. You also want to make sure that the mandible is projected above the foramen magnum so it's not covering the DENS. And remember, you achieve that mandible being above the foramen magnum by placing the mental-meatal line perpendicular to the image receptor. Cool, huh? All right, foramen magnum is here. It's a little bit difficult to see on this x-ray, but you can see the DENS is projected within the foramen magnum. All right, there is one last projection where you can visualize the DENS if you're having trouble seeing it in the AP open mouth. And that is called the wagging jaw projection. Okay, so in the wagging jaw projection, you position the skull just like you would for an AP open mouth. So in other words, you draw an imaginary line from the top teeth to the base of the skull, and that line should be perpendicular to your image receptor. So just like the AP open mouth, you already know how to do that. The mandible, however, in this projection should be constantly moving during the exposure. So this is kind of silly if you can imagine. You don't want the head to move, you don't even want the teeth to make contact, but you want the mandible to move up and down while you make your exposure. Well, what is that motion going to do during our x-ray? Right, it's going to blur some structures. So the purpose is to blur the mandible so you can visualize C1, C2. Again, this is an alternative to the AP open mouth if you're having trouble visualizing that dens. So let's take a look at an example here. So here is an AP wagging jaw. So look at how nicely you can see the dens and the zygapophyseal joints. Now, I would argue the base of the skull here is covering the tip of the dens, so it's not ideal. But again, this is an alternative if you're struggling to capture this C1, C2 area in another X-ray. Okay, you have blurring of the mandible, which is achieved by the motion. You want to look and make sure there's no rotation. So your zygapophyseal joints should look symmetrical. Your base of your skull should look symmetrical. And then your mandible here, this is your mandible way down here, should look symmetrical. All right, I've never seen the wagging jaw used in practice, but it is an option if you need to capture that C1, C2 area. Okay, there is one last projection that I want you to be familiar with, and that is called the AP axial vertebral arch or pillars projection. So this projection, you can tell, uses a tube angle because of the name axial in the title. Think about a routine AP C-spine. That is also an AP axial. In a routine AP C-spine, remember we use a cephalic tube angle. This projection is almost identical except you use a caudal tube angle. And we're going to use a little bit more, 20 to 30, rather than the 15 to 20 that we use for the AP of the routine C-spine. This projection is done for pathology that involves the articular pillars of the cervical vertebrae. So do you remember what that is? Look at the articular pillar is this chunk of bone in between the superior articular process and the inferior articular process. So this projection shows us that chunk of bone very nicely. It also shows us the spinous processes of the cervical and thoracic vertebrae, particularly in patients with a whiplash type injury. So that's when we would use this, okay? So you can see the patient is supine and you ask them to hyperextend their neck if possible. So again, look up at the ceiling and really lift that chin up. Then you're going to throw on a 20 to 30 degree caudal tube angle, and really your tube angle should match that natural curvature of their neck, which you can see is achieved here in this diagram here. The central ray should be directed to approximately C4, C5, again, just like a typical cervical spine x-ray, and you ask the patient to hold their breath and don't swallow. So this is almost identical to the routine AP that we do, except you put a caudal tube angle on. So let's look at the finished product. So here is your finished x-ray. And you can see how nicely we see that chunk of bone or that articular pillar on each side here. Okay, think about that for a second. These are also the Z joints, right? So you're seeing that articular pillar or that chunk of bone, and you're seeing the zygapophyseal joints. Kind of cool. Look at how nicely you see the spinous processes also. You want to check for rotation, again, looking at the mandible, making sure the spine is straight. All of those are indications of no rotation. Oh, look at how nicely you see the dens and the C1, C2 zygapophyseal joints. Again, the mandible should be above C3, so you're really looking at C4 through C7 here. And let's compare it to our normal AP. So here is a routine AP C-spine, and here is the articular pillars. So here we're using a cephalic tube angle, here we're using a caudal tube angle. Cool, okay, so listen, if you got an order for any of these special projections, excluding the flexion extension, because those are pretty common, you simply look in your Bontrager and recall how to do these. I don't expect you to be experts in these special projections. I just want you to have heard of them so that if one comes up, you're familiar with the purpose. So just remember, the Fuchs in the jud and the wagging jaw are all done to see the dens and that C1, C2 area. The apiaxial pillars projection is done to see the articular pillars of the cervical spine as well as the spinous processes. All right, any questions with this, please let me know.